we have a fairly full agenda today, with a couple of particularly significant items. Probably number one of which is the review of our future workforce implementation and the work that's been done on looking at how our plans square up with the Equalities Act, and I'd like to give time to have a good conversation about that. We have, as usual, public online through the web. Could anybody who's watching us on the web please take a couple of minutes to fill in the feedback form, if you can? We'd be grateful if you're able to do that. We have some apologies for absence. On the non-exec side, Stephen Duncan's not here with us today, and executives Roger Rawlinson, HR, and Sarah Field, corporate, are not here, but they've both made significant contributions to the content of the meeting today. I haven't had any declarations of interest. None? Okay. Then let's move on to the minutes of the last meeting, which was on the 26th of March. Are there any matters of accuracy? Okay, that's great. The action log then.
Shall I navigate us through it?
Would you mind? That would be great.
So the first two are in progress, but not yet due. The roster implementation is on the agenda, so we'll come to that in just a second. Trevor, do you want to respond in terms of TAL?
Yes, the TAL contract is being printed for sign-off, and we expect that imminently. So we will confirm when that has been completed to all board members. And the second point within that action was around the cost improvement programme and inclusion of the waterfall chart, which we've put into the finance report.
And in the absence of doubt, TAL is the appointments line.
It is indeed, yes. Sorry,
I'm afraid watching this thing being signed has been like watching paint dry, but hopefully it will happen very shortly. Can I just pick up, Roger Rawlinson did actually circulate to all board members prior to the meeting, and obviously Roger's not here today to speak for himself, but just the three items, I'll give you the headlines. Comparisons with other organisations in the NHS on the questions raised. I mean, generally, I think it would be fair to say that our scores were lower than the comparator organisations, and that was set out in Roger's response. Secondly, the proportion of our staff who are describe themselves as disabled is higher than other organisations listed from the information available from the Healthcare Commission, and quite substantially higher. And then the third action from Roger was last year's question on management support. We think understated the level of management support that staff actually felt they had from their first line manager, and because of the way that the questions were sequenced. And it led people to interpret management as being the kind of the them out there, the them up there, rather than my team manager who I know and love. Whereas this year's question wasn't sequenced in that way, and that therefore showed a big change. So I think basically last year's very poor result in terms of the feedback of staff, in terms of team managers, was an understatement of the truth, and therefore the improvement we've seen this year is an overstatement of the improvement.
And it was, in your view, it's an artefact of the questionnaire.
Well, I think it rings true to me that was Roger's response. Yeah. So those are the actions.
Trevor.
Yeah, I guess we all felt disappointed when we saw how much our staff feel less satisfied with their work than colleagues across the rest of the NHS.
Yeah.
I wonder whether the executive team have discussed those results and whether you've formed any conclusions why that's the position.
Well, certainly from the answer is yes. We have discussed it. There is no doubt that the level of uncertainty that is affecting this organisation is for a frontline service is probably the greatest of any in the NHS. Clearly for commissioning organisations and other parts of the kind of management structure, the uncertainty is one would argue is at least the same or possibly even greater. But the level of uncertainty and the sense therefore of not knowing what tomorrow or next year brings I think is bound to affect a whole series of things in terms of everyone's mind set at work. So that's our view, really.
I guess those of us, most of us, all of us who've been through staff surveys in different organisations and different situations, that would think that rings true. Trevor, would you think so?
I would, yeah.
Okay. So if you're not certain about what the future brings, it affects everything, every aspect of your work. It's very demoralising. Okay. Thank you. Any other questions? Is there anything else on the action log you wanted to pick up?
That's it.
No. All right. So, do we have Chair's engagement report? Happy to answer any questions on that. I think there was a slight inaccuracy. The meeting, the all-party parliamentary group, was the subject of the meeting was progress since the Wanderers report, and I'm sad to tell you that Derek Wanderers wasn't actually in attendance. Okay, let's move on then to the performance section of the agenda. Nick, your Chief Executive's report.
Thank you. I thought it was appropriate, particularly as we were discussing rostering as a substantive issue later in the agenda, that I just brought some focus to the impact that the rostering has had, our new approach, since the launch of the rosters on the 26th of March. And very broadly speaking, and I might just invite Keith to talk about a bit in some more detail, and we may also touch on it in the detailed performance report. But broadly speaking, whilst it is early days and there are still things that need to settle down, including the approach to flexible working requests, which we'll discuss as a substantive item, our performance has improved and we've seen benefits coming from the approach. We do still have gaps in terms of the numbers of nurses that we need at different times of the week, and that is now not so much a question of rostering, but a question of having the right numbers of nurses, which we're also addressing as vigorously as we can. So, Keith, I don't think there's anything you wanted to add.
No, I think you've summed it up very well. The only thing I would add to that is a little bit more detail that in the first week of the rosters, we had good performance improvement. The 2 weeks around Easter, we roster separately as exceptional periods, and that's in order to protect the Easter weekend itself. And we achieved significantly better this Easter than last Easter. And we've got now into a more steady state. So since last Monday, we've achieved our performance targets consistently, including over the weekend, all 3 days of the weekend for the first time for a few months. As Nick says, the critical issue is still the volume of nurses, and that's impacting our ability to meet some of the lower clinical targets.
Okay, thank you. Does anyone have any questions about that?
Not questions as such, but the Easter performance was fantastic. I just sort of wanted to pause on that because we sort of skated over it a bit.
Yeah.
I mean, the number of years I've been here, that seems to be substantially better than certainly last year anyway. Were there other factors that contributed to that, in addition to the roster fit?
Yes.
Or
There were other factors. Firstly, we had done an awful lot of planning, an awful lot of preparation. We'd also loaded the rosters towards the 4 days of the weekend, so we did suffer a little bit in the early part of the week, and the latter part of the following week we did condense the rosters, so we protected those 4 days. And also elements of the click to callbacks were switched off for a few days because there were some improvements and enhancements due to go live which hadn't been tested, so we didn't allow those to go in untested on the Thursday beforehand. So those were the main reasons.
was demand similar to what we would have expected?
It was, yes.
That's excellent.
Very good. Thank you. It's great to be able to know that, because after all, those are the times when people want us most. It's marvellous to be able to
And
provide
we
such
are
good service.
also obviously keeping our balls floating in the air for this bank holiday weekend coming up,
Yeah.
and then the next big one will be the Jubilee. So
And,
we're repeating our processes for that.
And we should absolutely recognise the staff who are effectively giving up their Easters and bank holidays so that we can provide good service to the public over that period, and that's a significant thing. And we should really recognise that. And we do. Okay, Nick, anything else?
I will pause very briefly on statutory mandatory training, just to note that we managed to achieve that at the year end, which is really good. I'll pause in that case.
Well, I do think, because we were concerned quite strongly about whether this would happen or not.
Yeah.
And the executive team gave an undertaking to achieve it, which they have done, and that should be thoroughly recognised, and also the fact that the staff have responded during a busy period as well in contributing to this. So it's very important that that is recognised properly.
Yeah. Clinical Governance Committee would definitely agree with that as well.
I thought it was worthy of inclusion in my report, just to highlight
very
it.
much so.
Just pausing briefly on health information. My comments earlier about the degree of uncertainty that exists in the organisation is actually magnified substantially for health information staff, where a late change to the national minimum specification for 111 includes some elements of health information, but because it was a late addition, many commissioners are not really clear what service they're going to actually want to buy, or how to interpret that specification in reality. And therefore we are seeing many of the procurements happen without the clarity about what health information is or is not included that's necessary. And Tricia, myself and Joshua went through, and with Anna Turner's help, went through a process of having briefings for health information staff, which we did by teleconference, which worked out reasonably well. It made it practical to get this thing to happen with face-to-face time with myself and Tricia, etc. So I hope we've dispelled some of the uncertainty by giving clarity to people about what we know and what we don't know. It's only a partial degree of let-off, but there it is.
I mean, it is worth observing that the lack of clarity around health information in the 111 service. I mean, after all, it's an extremely important part of what we do, and reflects the fact that the public feels a need for and uses a health information service. So I think the fact that there is still some uncertainty about how it's being built into 111 is really regrettable.
Well, I think, Ruth might have a comment on this, but the position nationally and the reason for the late inclusion of health information in the minimum specification was because there was a recognition that it was included within 0845, and it shouldn't simply go by the board, and therefore they incorporated health information into the specification. But the way that commissioners are actually responding to that hasn't quite caught up with that. There's a delay, and therefore we don't know how commissioners will actually respond.
And how many health information calls do we get in a year?
About 300,000. We've got just over 100, about 120 health information stuff.
Thank you.
Joanne?
Okay.
Sorry.
Tim, sorry.
Could I ask, so is there a danger that this valuable resource could be dissipated?
Yeah, absolutely. Yes, absolutely.
And then reassembled in bits? Okay.
And then finally, as the board knows, I try to be assiduous in keeping the board up to date with the implementation of Cabinet Office guidelines. You may all have seen that this is broken out into the public domain in the form of reports coming through from the Health Service Journal, and my specific comment, which was that we absolutely were 100% behind the implementation of Cabinet Office guidelines, and where we were having difficulties with both commissioners and providers, that we have escalated the matter formally to the Department of Health, and that is where it currently sits.
Well, this board noted at our last meeting real discomfort at the fact that those Cabinet Office guidelines didn't appear to have been embedded in the bidding process. So I guess that carries on. Trevor?
I wonder whether we could have a wee bit more detail on, this simply says that no transfer undertakings have been signed.
Mm-hmm.
We know how critical this is for the NHS.
Yep.
It will reduce the cost of the public purse of the change in the NHS. I think our figure was about £50 million.
Correct.
It also will ensure that very scarce clinical resources in the NHS are used to best effect. And I'm really concerned that some parts of the NHS feel we should spend £50 million unnecessarily by not following Cabinet Office guidance, and that potentially nurses could be made redundant unnecessarily. So I wonder if you could give us a wee bit more detail on the discussions that are taking place.
Certainly. There are about 7 sets of discussions currently taking place, and they're being transacted through Roger with specific local health communities in relation to 111 services that will transfer to other providers. And I think it would be fair to say that there isn't a single one of those where the approach of the local health community is a simple agreement to apply the arrangements that have been hammered out, I think is the right description, between ourselves, the NHS Midlands and East, acting on behalf of the SHAs who commissioned on the 0845 service, and the Department of Health 111 team. We have an agreement about how all of the matters related to the transfer of 0845 responsibility should take place, and that ties together transfer of funding, transfer of staff, and transfer of call handling and clinical assessment responsibility. Ties it together, and we haven't yet had the simple case of somebody saying, I understand what I've got to do, where have I got to sign? And that is the approach that we have to get to. When all's said and done, NHS Direct does not have the authority to instruct, command, or to do anything other than seek to facilitate and be helpful in the application of that agreement. It's a matter for the Strategic Health Authorities first and foremost, but also a matter for the Department of Health, as ultimately they are the ones that would pick up the financial consequences and have to see that they were dealt with.
It's a great shame that the local health communities in the shape of the commissioners weren't brought in to this, and they feel it appears no ownership of it.
Just on a practical level, I mean, as new contracts are implemented, surely the normal practice for tutoring people from one place to another would apply.
Correct.
So ignoring this formality for the moment, it would seem to me that the actual implication for the successful contractor is to enable that to occur. And if we do nothing, then I'm sure that trade union colleagues will be looking at that as well. I mean, I can't quite fathom why it's so silent, because it's just normal practice and custom and practice, even forgetting the cabinet sort of arrangements that we've talked about. So that to me is curious and strange.
I mean, the technicality is that TUPE itself would not apply because our staff take from a national call mix, and what's being transferred are local call mixes, and that's the technicality. But in every other respect, I mean, TUPE is not an easy thing for an incoming provider to take on. It's normally a complicated and difficult process that requires very active management from the outset of even putting in a bid. I think it's the notion that somehow that whole hassle can be avoided that is the gleam in some provider's eyes, and that is essentially what we are seeking to combat.
Tricia?
On the particular issue of losing nurses and clinical staff to the NHS, I have raised my concerns and the board's concerns with the Chief Nursing Officer's office through Viv Bennett and Jane Cummings.
Joe?
If I can just come back, I don't think we should take any sort of solace from the fact that SHAs will be managing this process, because the point where staff would transfer will be very, very close to the point where strategic health authorities disappear themselves. So the regulator in the system won't exist. And my real fear is that we have a significant number of very well qualified nurses not transferring to colleague organisations within the NHS. And Nick said the department will have to find the cash. The department won't. This cash will come out of the NHS budget. Patients will suffer by up to £50 million unless people have a bit of common sense on it.
I think all we can say, Trevor, is that Nick and the team are doing absolutely everything possible to raise those issues, talking to the right people, escalating it to the very highest levels, and we'll continue to do so, I know.
And I'm ever optimistic that we will reach a conclusion which is the implementation of the agreement that the department initially has, well, not just initially, but has signed up to and wants to see enacted. And I regard everything else as simply confusion along the way, which we will no doubt manage to dissipate.
Fine, is there any other questions to Nick on anything, not necessarily in this report? Can I then just take the opportunity to say that to congratulate our multi-channel team on the winning of the
Carphone
Warehouse app, Health and Wellbeing app award, which is fantastic, really. Public recognition of the value that is being added, and not just the multi-channel team, but all the people who sit behind it, and the people who answer the phones when people click to call back, and the communications team who let everybody know that this award was coming up. It's a great piece of teamwork, reflecting the underlying quality and value in the online service, and the app element of the online service. So that's great. All right, shall we move on then to the performance pack? Trevor.
Thank you, Chair. Operating results. Firstly, March was another difficult and challenging month, but we did show improvement across a number of areas. As members will see from the scorecard, we had improvements across 19 specific performance indicators, 6 went down and 3 non-movers. In terms of volumes of activity, we had 1.5 million contacts with our telephone and online service this month. We were again able to provide self-care advice for over half of all of our users of 0845 services, so that they required no onward referral to other NHS services. Whilst we generally performed better on access into the service, we do recognise we need to improve further around less urgent and non-urgent clinical assessment times.
And we talked about the reasons for that already.
Absolutely, yeah. And we're working on those as we go through the first quarter of this year. Our patient satisfaction levels remained good at 92%, and complaints were just 0.12 per 10,000 calls.
Okay, can I take questions on the operational performance side of our equation? Tim.
Thank you. I did notice on page 3 of 12, actions arising from complaints implemented the deadline for 2 months running. We've got 100%, which is pretty good, actually. Real high standard. I thought that was very, very good. So those response teams need a good pat on the back, because although we're always above target, to hit 100% 2 months running is really fantastic.
Thanks, Tim. That's definitely worth noting. Okay, well, I think what this reflects is the crystal clarity of the information that we receive. I mean, these graphs are really fantastic. As a means of letting us and anyone else who's interested get a really clear picture of our performance. So shall we then move on to the finance?
We ended the financial year with a surplus of £488,000 and cash balances of £22 million. During the year we delivered over £15 million of cost improvement, and we managed to meet a number of non-recurrent costs that fell due during the course of the year. We also invested nearly £3 million in capital assets. Our accounts are currently subject to their annual review by the National Audit Office. Their work should be complete late May, early June, in time for consideration by the Audit Committee and Board during that month.
That's great. Questions on finance, Peter, or comments? Chair of the Audit Committee.
Yeah, well, I mean, again, it's a bit like Easter performance. This is a very good set of financial outcomes, and a lot of work and effort has gone into achieving this. I know many trusts in the NHS who have not been able to do this and are struggling with their financial position, and NHS as a whole is struggling with its financial position. I particularly would like to say that the achievement of the cost improvement programme through a period of change is a very major thing to have got through. And also the in-year adjustments that have been made by the team haven't, some of them, well, they've been minor to some extent, but it's been a steady ship all the way through. And that's to be commended strongly in these difficult times. It is the simple things that we've achieved here that are the commendable bits. It's not having a crisis with this that is, I think, should be mentioned here. And as a board, I think the whole of the organisation has contributed to this as well. That's the other thing. It's not just a top team thing, it's the whole of the organisation. And it shows what NHS Direct can do. And for me, it's very important that everyone out there knows about this, and it isn't just seen as we've quietly achieved it. I think this should be broadcast quite strongly. So, brilliant.
I'm going to come in there before Tim, because I just want to underline two of the things you said, Peter. I agree with everything. I thought that the spot-on delivery of cost improvement programmes was extraordinary, and that's about, it seems to me, the effective joint working between the finance team, which sets these difficult and challenging targets, and the organisation that rises to meet them. So that was fantastic, I thought. The other thing which I absolutely agree with is that we know and we have made public the inevitable costs of decommissioning our service. So there are going to be some substantial negative numbers coming through this board, and they are absolutely unavoidable, and they are the consequence of policy decisions that have been made. And it's vital that we communicate the fact that on a business as usual, always challenging business as usual basis, this organisation has delivered exactly what it was asked to in terms of finances, and that message mustn't be lost in what will inevitably be some difficult messages about decommissioning costs which are going to come through. Tim.
Thank you, Joanne. Two things really. First of all, the Finance Committee, I guess, I've said there, I'll say here, at this stage of the year, boring is good, and so that being absolutely congratulated. The other thing I'd just like to comment on, whether I misread this or not, but in 3.2 on page 5, it shows there's a 2.2 million overspend on permanent in-source health advisors.
Sorry, could you speak up?
A 2.2 overspend on permanent and in-sourced health advisors due to additional staff with bank holidays. I assume that our new rostering arrangements will actually reduce that overspend and really get to grips with it. So there is some good news that we've got some action in here that's going to make this even better.
Great, thank you. Is there anything else? No? Peter?
I did want to go back on the scorecard.
Yeah.
I'm sorry. It's just that when you look at the value to patients in the NHS, it still strikes me so strongly about the performance of the 0845 number regarding onward referrals being 51% as it is now, compared to 27% for the 111 service, and the urgent and emergency onward referral, which although for us it's 30%, it's 43 for 111. I do feel that those are significant differences, which and it's been broadcast so many times, but it hits you in the eye every time you see these numbers, and I just wanted to say that.
Yeah, it's worth saying. I think it's a difficult message for the wider world to hear, particularly those who are responsible for rolling out 111. It's not a message that people want to hear particularly, but it's the truth, and we have a responsibility to make it clear.
I think so, and I mean it's in our business plan. I mean it's very much should be at the forefront of all the things we're saying. But I don't think it is heard, personally.
Not for want of appropriate communication, I would say.
No, for whatever reason. Anyway, thank you.
Is there anything more
Get
to
that off my
add?
chest, thank you.
No, well, the only thing I would add is that we have landed the point with the 111 programme nationally that in none of the pilots to date has there been a condition where the 0845 calls that we handle are put through the 111 system. So there are two differing views about why those numbers that you highlight, Peter, are different. The first is that it's entirely down to case mix. In other words, people with more urgent needs call their GP out of hours, they don't call 0845. And that when you put 0845 through 111, you'll see the lower priority calls bringing down, increasing the, or bringing down the face-to-face referral rate.
Right.
So one view is it's down to call mix. Yeah. The other view is that there is a fundamental difference between the nature of the process of assessment and signposting in 111 compared to 0845, and that when you put the 0845 calls through 111, they will behave like the 111 calls currently do. And you will see a substantial rise in the face-to-face referral. Our view is that is a danger and a potential outcome, and that what we need in the face of this is data.
Yes, absolutely.
To know with a bit more certainty how this is actually going to impact. And the Department of Health agree with us, but they have not yet agreed to the detailed arrangements for us to conduct that experiment.
Yeah.
I mean, it's so critical.
So
critical, I can't express it. That this is a question that has been hanging out there for months and months and months. And the only way that's going to get cracked is to get 0845 calls through the 111 system. And we need to do it with a real sense of urgency.
Yes.
And yet what I think you just said, Nick, is that we haven't actually reached agreement yet.
Not quite, but Tricia is on the case.
Yeah, we have a project initiation which is now with DH to take to the 111 National Programme Board and give it final sign-off, and we hope that trial, once approved, will start in very early May.
And can I ask, how long is the trial? Do we think the trial will need to be to prove one way or another that?
Within the PID it says for 6 weeks. What we have identified is that we will continue it for longer should partners agree that would be beneficial.
The more data you've got, the more
better.
Yeah.
And do we have independent analysis because of that all lined up?
Yes, we have. We've got analysis from the Department of Health, internally within NHS Direct, and externally and neutral.
Office of Health Economics.
Yeah.
Okay, all right.
Office of Health Economics.
So in fact, it will be running exactly the same time as the procurement plan is being finalised and finished off. So we'll have the data probably at the end of the procurement round.
As long as we get Department of Health sign off.
No, but I mean it'll be at the end of the procurement round.
Bit too late.
I'm not sure what value that
Yes.
has, other than out of interest.
Well, because I guess it's important because it is an issue, and there needs to be some demand management.
Exactly, and it sets expectations, and the people who are taking on 111 need to understand what's likely to happen.
Yes.
It's vital to do it. I mean, obviously, it should have been done a long time ago as part of a business case for the rollout of 111, which, as we know, wasn't something that was done. So we are very much playing catch-up. Better to do it now than not at all.
Indeed.
Chair, can I just assert the point Peter made with regards to the urgency and acuity of the calls that do come into NHS Direct?
Yeah.
There is a belief by some commissioners that we are a low acuity provider. I have been arguing and demonstrating and had it acknowledged by our Commissioner, Midlands and East, that our service is equal to an out-of-hours provider.
Yep.
Therefore, the difference between the 30% and the 40% plus is even greater, that we can actually conclude more calls within the service.
Okay, well, thank you, everyone. I think that was helpful. We're obviously very keen to see that pilot or that test go ahead. Thanks, Peter. All right. So that concludes the performance section of our agenda formally, although of course a number of things we talked about were more strategic than about our own performance. We now move on to the formal strategy element of the agenda, the first item of which is our business plan. So colleagues will recall that a draft of the business plan came to the last board, and the conversation really centred around the balance and tone of the business plan and how far it reflected, it's an update of a 5-year plan, but how far a reader would really be able to tell the situation that we're in. So this further iteration has come to us, and I'd like to take comments from people, if that's okay. Nick, would you like to say anything more?
I think the assiduous reader will discover that the number of changes in the actual document are relatively few, and that what we have actually done in the statement that Joanne and I make in the foreword is to make it perfectly plain that the reality is that whilst this is a follow-through of our 5-year strategy that we agreed some while ago now, that this will need to be reassessed mid-year in 2012 in the light of what happens on the rollout of 111. The truth is we could have written a document with lots of ifs and buts and maybes, or even 2 documents or 3 documents depending on what the scenario is, and instead we've opted to do a light touch repeat and update of our original strategy, but acknowledge that it may have to change quite radically mid-year depending on the outcome of the rollout of 111, and that's the flavour we've adopted, and I hope that that's satisfactory. Any more speculative approach of, well, if A then B and if C then D in the business plan would have caused, I think, substantial difficulty in the minds of commissioners as we went through the procurement process, and would have been pretty self-defeating. So that's my defence for why we've kept it as it is, but put in that really important, and I'm grateful that was reflected fully in the minutes.
Okay. Has anybody got any questions or comments? Sue?
I'm persuaded that the risks are clear in here, and I think the forward is better captures the balance of those risks.
I do have a couple of further tweaks I'd like to make to the forward, but if you're happy, I'll do that offline.
Yeah.
It's all about that alignment between the reality and just making it clear in a balanced way. Okay, thank you very much, everyone. We're going to take this away. With your permission, make a couple of further tweaks to the text, but not affecting the sense of it. Well, that was very quick and helpful, which is good because it enables us to spend time where we really feel that we want to on looking at the latest developments in our future workforce implementation. Nick, would you mind introducing that for us?
Not at all. Can I first introduce Eleanor Tunnicliffe, who will come to the table. Eleanor works for Beechcroft, who have been advising us on the legal aspects of this. I would also like to just reiterate, of course, for reasons that the board will know, Roger's not been able to be here today through family bereavement. So clearly Roger has been very central to taking us through this process. But I'm ably assisted with in addressing this with the board by having Keith with us. So I'll just very quickly introduce the topic by saying that the board made some major decisions back in November last year and did so on the basis of the business imperative that we faced, both in meeting our efficiency gains, and we just rehearsed the year-end where we had a substantial cost improvement programme. Well, this year's cost improvement programme that we've just started has a very major element of it that is determined by improvements in our frontline efficiency. So there are very clear business understanding that the board had back in November. However, it is clear that we did not have sufficient understanding at a detailed level to enable us to predict the application of the new rosters and the numbers of flexible working requests that it would generate. And we reached a point in the year where, through presentations made to us by the RCN that challenged what we were doing, that we needed to go back and start again in terms of looking at the application of the flexible working policy in the context of the new rosters. And the way that we've done that is to get much more granular information about the numbers of staff and the types of impact that the new rosters are having for those staff who are dissatisfied with their new rosters and have therefore put in flexible working requests. We have had legal advice, and Eleanor will I'm sure be happy to answer questions about the legality of our approach as we stand today. But we've taken advice on how we can ensure that we are meeting the requirements of the Equalities Act. And essentially, through the process that we've adopted outside of the board and today's board meeting, we believe that the board will have met its duty to pay due regard to the Equalities Act in setting out the framework for how flexible working requests will be dealt with. We've had the opportunity of a board workshop, and very kindly Sue and Peter participated in that together with Tricia, Keith, Roger and myself, advised by our lawyers as well, and that the outcome of that is set out in these papers and public papers, where we form the view that with the business imperatives that exist and still exist for us, that we can accommodate the predicted number of people whose disability will materially impact, or the shift patterns will materially impact on their health through their disability, and that we will be able to have a fair application of the process to hear those flexible working requests and reach conclusions. But at the same time, we have looked at the implications for people who have caring responsibilities and have formed the view that it will not be possible for us to accommodate flexible working requests for that reason, because of the number and the impact that it would have on the organisation and its imperatives. We've also taken due regard to the other protected groups, religious belief being the most salient of those, where shift patterns could clearly impact on the days that people worked, and have come to the conclusion that the mitigations that we have put in place are sufficient for that group. We put forward a clear plan for implementation, but with a review built into it, so that the board can revisit how the implementation is affecting our staff and ensuring that we continue to meet our duties under the Equalities Act. It's been a complicated process. There is a lot of information here. I would like to apologise to the board for the fact that you had the weekend to read it and not longer, and that's simply been due to the process that we've had to go through to get sufficient granularity. I think that we have a set of guidelines now that will meet the requirements that we have, the legal requirements that we have, but I'm sure that there will be questions. I should have cited Tricia as having been deeply involved in this. Forgive me, Tricia, you have as well. But I don't know if there's anything that Tricia or Keith want to add from my rather wordy summary.
So what I'd like to do, Nick, is see whether Tricia or Keith have anything to say. Ask Sue and Peter what their perspective is, and then throw it over.
Yep.
Nothing further to say.
The only point I would like to add is to perhaps the most relevant is to draw the board's attention to the graph at point 8 in Appendix 1, which is the need for our more efficient rosters. And the blue line there shows our forecast core requirements, and the green line shows our new rosters matching that forecast requirement very closely. The red line shows how our old rosters did not match that, and that really sums up the need for it for me. Nothing further to add.
Okay. See you, Peter.
I'm happy. I would just like to say that I think the legal advice that NHS directors have been given is excellent. I've seen other advice in other places around similar matters. It's not that dissimilar, but I think for me it's balancing the, as you called it, the business imperative with the needs of the people who have protected characteristics, and ensuring that as best can be done, we can accommodate their needs. And this is an excruciating issue, I think, and one that's played out across a lot of the public sector recently. So I think this is a good piece of work. I think the detail work that has been done to produce the required data to show the impact is clearly there. It also prioritises the people who have protected characteristics in the correct way, in my view, with those who have disabilities under the Act being clearly identified as top priority, with a system to enable those like carers and people with religious beliefs to make their views known and for them to be considered. Those are the most important things, I think, in this. But the difficult thing, I think, for everyone to get to grips with is how to get that balance right. And I think that, because if you're in a commercial business, then potentially your business would cease to exist, and therefore there's no jobs for anybody. So there has to be a balance, and I believe this not only achieves that balance, but actually gives an underpinning evidence base to help understand why that decision was reached. And the key thing for me also is having a review mechanism that the board can come back on a regular basis. So I think it's a really excellent piece of work, and I'm grateful to be involved in it. Thank you.
Thanks, Peter. Sue.
Not much to add to that, really, other than that, certainly from my perspective, I think in the workshop we thoroughly considered every aspect of a very, very complex situation, ably advised by Beechcroft's. I think the paper is very clear and concise and well structured, sets out our conclusions and actions, and I would add my support to the recommendation.
Thank you, Sue. Okay, I'm sure there are questions. Trevor.
Yeah, first of all, I should say that I haven't had an opportunity to go into as much detail I would like, because we did receive the papers late, as Nick said. So some of the things I may say may be simply a poor interpretation after a cursory glance at some of the documents. So it's a pity we didn't have them earlier, because this is a very critical subject, I think. The first thing I say is we must, as a board, comply with legislation. And the first thing I would seek assurance on is that the proposals as set out comply with the Equalities Act, allow us to meet our duties and the Equalities Act. I think it's important that we are absolutely clear of that reassurance. The second thing for me is the report sets out in paragraph 2.5 the test that is likely to be applied if we went to judicial review over this, to ensure that the process we followed meets acceptable standards. So I think it would be useful to get feedback on each of the points set out in paragraph 2.5, so that we can be assured that we have a strong process to follow. The final point for me is, when I read the report, I was uneasy around the way priorities were described in the text in the report. It's a very long section setting out how priorities will be set, when I read it, it seemed to focus very much on the issue of business performance, not on the issue of addressing the needs of the individual, either with a disability or with a particular need. I was lucky enough to have some time with Nick before the meeting, and I must say I was reassured in the discussion with Nick about what is intended by way of priorities. I'm not sure that the report as drafted necessarily sets that out. That's something Nick may want to reflect on after the discussion. I think it's important that the documents we have reflect precisely what we're trying to achieve through this. Because I certainly got the impression reading priorities are much more about if we get to 89% of performance, we will consider individual rotas. If we get to 91, we won't, rather than looking at the particular needs of the particular client. So in that, I'd like an assurance that applying this process will not result in inequality of treatment of individuals with the same needs within priority groups.
Okay.
And that's my point.
That's very helpful, Trevor, because my understanding is all those things have been covered, but they probably haven't been expressed quite clearly enough, and it would be, this is an opportunity to get those completely clear. Louisa, should we pick up some other points and then we'll come back?
Okay, so I just wanted to echo that I suppose I was surprised to get this collection of papers, and it was hard, you know, it was sort of quite sort of challenging and they were very clear, and I was very struck by the openness of the papers and how I think it reflects our commitment as an organisation to try and do the best not only for the public that we serve but for the people who work with us and make that possible. I wondered first of all, I can't remember where the 90% came from, that figure of, you know, 90% is the sort of gold standard for efficiency. And I wondered what other organisations have that.
I also spoke with, so as well as my own experience, I also spoke with the chair of the Professional Planning Forum, which is the industry body for people in call centres that do rostering. And they set the benchmarks for best practice for a number of things within the contact centre industry. However, roster fit and roster efficiency is one area where they've not been able to get any consistent standards because it's one of those things that everyone measures differently. They have said that 90% in the way that we measure it is quite ambitious, but is eminently achievable as we have demonstrated. There are other organisations that work to slightly less but measure it in a different way. There are other organisations that achieve 95% on the methodology that we have. So, for
these
example,
call centres that deal with sort of health.
No, they're general inbound call centres. So that's across the industry as a whole. So it's one of those areas that's very, very difficult to measure.
Because my concern is that if that is such a sort of salient sort of percentage, and we would be, you know, denying people, you know, these ISPs, because we need to achieve that. I suppose how realistic it is we could achieve that, and whether you know, whether it's realistic. I mean, I think the worst, we really don't want to sort of, you know, come off worse in any sort of judicial review. So obviously the main thing is that we are legally compliant. I wondered if we are legally compliant to say that, are we saying that there's a, I mean, I wasn't quite clear. In one paper it said that we would look at ISPs in exceptional circumstances for carers, but it seems that we might be saying that there's a policy of, which I thought probably didn't sound like it was legal, to say we will not have any ISPs for carers. So we're saying that we would have some ISPs for carers in exceptional circumstances.
Yeah.
Okay. It's possible. Okay. So we're saying we would.
Never say never.
Yeah, I think the point is that we would want to have the flexibility to look at it on a case-by-case basis, and we give an example in the recommendations
which is a short term.
what that case might look like.
Okay, but do we have a sense? And again, I'm sorry because I'm not sure that I'm completely all over these. Do we have a figure for how sort of high we could go with the number of ISPs we have, in order to relax that a bit, so that it wasn't life and death for carers? Or
It does vary because each ISP on its own may only have a minimal impact, but when they're grouped together, collectively they can have quite substantial impact. So you could have one that would on its own be quite a high impact. You could have perhaps 20 or 30 that would on their own be very, very low impact, but when grouped together would be significant.
Okay, so you don't just look for numbers, you have to look for patterns.
You have to look for patterns.
As well, okay. Then I suppose, when you talk to staff, they're always so sort of smart about what would work, and we're saying that there were no themes to these flexible working requests, and I suppose we've asked staff if they see that there are any themes or any ways around this.
Can I answer? So particularly around the issue with carers, the theme was very much around wanting to accommodate within the school run, but again there were no patterns there because some people wanted to be able to do the school run in the morning and then come to work, others wanted to be able to work and do the school run in the afternoon, others wanted to be able to do both school runs and come to work in the evening, so there wasn't a consistent theme. And again we do have roster patterns that accommodate each of those. We have shifts that are predominantly early, predominantly late and predominantly twilight.
Just to clarify that, I think if I understood you, Lucy, you're asking kind of a broader question, which is, have we asked staff whether they can come up with anything that would enable us to meet what we need and accommodate them? And I know that we absolutely have through the whole process of this roster initiative. Have we done that specifically around these ISP issues?
No, so the themes, the sort of conclusions we've drawn about the themes have come from a review of the flexible working applications, where people have kind of put brief comments on why it is that they want the particular shift pattern that they're asking for. So Julie's team went back and reviewed them. They also, in the course of processing the flexible working applications, have had quite a lot of conversations with staff about the reasons for their particular requests. But it's fair to say we haven't kind of gone back to staff with this proposal and said, here it is, what do you think? And that's basically because we've been very short of time to turn this around. And at the moment, all the flexible working applications are paused, which in itself is not great for staff. So that's basically why we drew the information from the applications rather than going back to staff.
Okay. In 13, which is on page 13. It says here, unfortunately, because the question that you would have was isn't it, sort of how would restrictions that we could ask for match up with the problems we've got now? And it says here, unfortunately, we no longer hold comprehensive data in an accessible format that would allow us to tell how many of those on Silver previously had restriction in place. I mean, what would
Which document are you referring to?
Oh, sorry, yeah, this one.
The private briefing.
Confidential briefing.
Yeah. So I wondered what that would give us if we did have that data.
It's just going back to this point of having the importance of having a really clear idea of who is affected and how they're affected and how many of those people there are. So we've identified the fact that it's the people who are now on fully flexible, who previously had restrictions in place, that are most likely to have the biggest negative impact. But we can't tell how many of those people in Silver did have restrictions beforehand. So if we had that information, we would just have a bit better idea of the numbers of people involved.
So we can't get that.
I think we don't have it easily accessible. There was a bit of a question mark as to whether if we went through every file for every HR file for every individual, maybe we could pull it out, but it wouldn't be a straightforward task.
Okay.
I've got one more. Can I just, so I know it's not an individual seminar here, but in this document here, which is your legal advice, you say in 12, the board paper concludes, page 14, while staff impact will be considerable, it has mitigated access to bank work by recourse to new flexible working policy. And that was certainly, I think our impression. And that we'll have a national shift swap, managed waiting pool for change of roster option and by greater job security. If people with care responsibilities say, well, actually I just can't fit in this rota, are we confident that we can offer enough to try and accommodate them, I suppose is what I'm saying. I'm particularly concerned about people who joined NHS direct because they could have restrictive working practices and are caring.
I'm not sure I quite understand are we confident that we will be able to accommodate all requests from people with childcare responsibilities, for example? Answer no.
No, that's not my question.
Sorry,
I'm sorry, my
misunderstood.
question, let me try and say it in a more clear way. when we looked at this before, we said that we agreed, and I think we're comforted by the sentence around the mitigation on staff
Yes.
impact. And I suppose I'm saying, is that still the case? And do we have a sense of whether what proportion of people we will not be able to accommodate and we will have to ask to go?
I think that the original mitigations of being able to have must-have days within your roster means that you can anchor your roster about certain commitments that you know you've got. I think those are set out in the PowerPoint. So seven must-haves in a month period, for example, which is quite significant. And I think the second mitigation, which I put a lot of stress on, is being able to have a healthy internal trade of shift swaps. So mutual gains by trade. I think certainly the feedback that I've received on the shift swap system that we put in to date is that it hasn't optimized the situation yet, but we're working on it. People are working on it to make it much more flexible, much easier to use, and much more likely to generate a higher volume of shift swaps. And I take the view that every shift swap that goes through, we have two people who feel better off as a result, and therefore a higher number, all other things being equal, is a better thing. So I think there's a bit more work to be done on the shift swap system.
Okay. Are there any more questions, Tim?
Yeah, I absolutely understand and concur with the legal imperative of getting this right. But do we know how the staff, the vast majority of our staff who don't have care, well, not the vast, the majority of our staff who don't have care or disability issues would view or indeed do view the prioritisation given to their colleagues? Because I do recall from many of my site visits an undercurrent of view that it seemed unfair to some of our members of staff that they had to do all the weekends, all the nights and so forth, whilst others, because of whatever their individual circumstances get a better deal. One of the key values I saw of the move that we've put in with the new rostering was not only to get us to better meet our service needs, but also actually create a better sense of corporate and equality within the staffing. And I'm just very, very anxious with this conversation to hear how far we might be backtracking from that. So do we know to what extent if you like, the healthy non-caring members of staff, non-disabled non-caring members of staff feel about these discussions? And do we know, for instance, whether they would support what we're doing for their disabled and caring colleagues? On 3.7 in the cover document, we say that it may result in some options being oversubscribed if we take account of disability. Staff already allocated should not be removed. But in fact, do we know that there aren't staff who are already allocated who don't have caring responsibilities who wouldn't be perfectly happy with a roster swap arrangement to make both parties better off? And to what extent can some of this be delivered, if you like, internally and between staff without being imposed with committee and review?
It's a big question. So what I'd like to do is just catch up on any other questions and then go back to things we need to answer.
Sure.
Okay. So I think what we've done is we've basically picked off most of Louisa's questions on the way through. We're left with Trevor's sort of three clear challenges. Are we sure we're legal?
Application of the tests under 2.5.
Oh yeah, absolutely.
And
the way that so I think the third one we don't have to worry about at the moment, so that was about the way that we describe the priorities. Yes, get some feedback on the points in paragraph 2.5. And then Tim's question, which is how does this play to other members of staff, and are there better ways of enabling them to work it out between them? Okay, can we just go through those three things? I think.
Should we go through them in that order?
Yeah, that'd be good.
Can I think I said in my piece that I thought what we were doing would enable us to comply, but can I ask our legal advisor to give a view?
As Nick said, I was involved in the workshop that pulled together these recommendations, and I'm comfortable with them. That does go with a caveat though, which is that you guys understand your organisation much better than I do. So for example, that discussion that Louisa was having with Keith about where does the 90% come from, how big is that in terms of business needs, how critical is that? you will understand those business needs better than I do. You will also understand your staff, you know, what they've gone through over the last few years much better than I do, which is why as a board I think it's sensible to go through the exercise that you've suggested of just looking at those points at 2.5 and saying, are we comfortable that we've got all the information that we need in order to make this decision. So it's on page 4 of the briefing paper. So and the first one is to be clear about the factors driving the decision, even if these are unpalatable. Those are set out in the briefing paper, which has had quite substantial input from Keith, from Jill Kemp and Ross Dring, and also Roger and Julie in the HRT.
Just before moving to the point, can I raise one thing that was interesting when I was talking to Nick? I realised there's two interpretations of this. What is the decision? I assumed the decision was the decision we have already taken to implement the rosters. Nick's view, I think, was that the decision is the thing we are about to do when you read 2.5.
Yeah.
Does 2.5... It's what? It's what?
That decision, how you implement.
The flexible,
Right.
the flexible working policy.
It's not the decision that has been challenged by the RCN.
The thing that's been challenged by the RCN is our application of the flexible working policy.
Right. I just want to be absolutely clear what the
that we
decision
are
is.
deciding here.
Amongst other things.
How do we apply?
Can I just say they have raised a lot more than just this.
I know, I've seen it.
Of which it's boiled down to this being the issue. So.
But we're clear the decision is what is about to happen,
Correct.
not the thing that has been challenged. That's helpful.
Basically, what you're doing is revisiting the decision about the flexible working policy, because when it came to you last time, there was an assumption that there would be a handful of flexible working applications. It turns out there's 240. There have been difficulties about how to apply that on the ground, so that's why it's coming back to you to decide how should we apply it on the ground.
Okay, so shall we go through those 2.5 points, which is page 4 of the board paper. Nick, do you want to just walk us through them?
Okay. Being clear about the factors driving the decision, even if they're unpalatable, I'm quite clear on 2 grounds. Notwithstanding the discussion about, well, there isn't an absolute benchmark. Well, I'm sure there isn't an absolute benchmark, but I do know the degree of competition that we face, and I also know the imperatives about this year's requirements for cost improvements, which are no different to the rest of the NHS, of another 4%. So I'm quite clear that whilst we make savings in across the board in the organisation, including in back office, that if we were to take a decision that we didn't need to make any further savings, we would be significantly adrift in what we're bidding for in terms of 111, but also would be adrift now in terms of delivery of this year's budget.
Yeah, I think that's very clear.
Okay.
Thank you.
Are we clear about who is likely to be affected and how? I think there is no absolute clarity exactly who the names and addresses of everybody and exactly how they will be affected, but we do know the people who are the most unhappy with the roster choices that they ended up with, so much so that they put in flexible working requests. And we've gone through in some detail to understand what protected characteristics there are amongst that group and how it's affected. So I think we've got the granularity there.
Yes, I agree.
Yeah. I think in so doing we have gone through, and in making the decisions, understanding the impact, keeping it under review, because we will gain more information as we go through this process. We do need to explain the rationale, so we do need to have some communication, which will follow the board discussion. But I think we've been clear about that, and I think we've been clear about the mitigations, what we can do and what we can't do, what we've already done and what we can do more of.
And does that cover the point about protected groups?
So Trevor's anxiety is that we set a business-related, if I'm correctly interpreting it, a business-related, absolute kind of red line across which the organisation cannot cross. And through an arbitrary process of who happens to turn up when, people with equal needs, some will be the right side of the line and some will be the wrong side of the line. And it will end up being unfair because we say, oh, I'm sorry, shop's closed, we've used up all of our flexibility, even though you've got the same needs as the person we've just
and I think
agreed to.
That issue of equity between our staff is a very important one, and it
bears in on
Tim's points as well. So are we confident that we are treating our staff equitably?
So my interpretation of what we are doing, I'm grateful for Eleanor's view that this is correct, is that what we're setting here is some overall guidelines that say we've assessed how we should prioritise between the different groups of staff, but not between individuals within those groups. We've set broad parameters that say we believe that we will be able to make accommodations in the form of individual shift patterns for those limited number of people who we assess will have real health issues related to their disability under the Act from the shift patterns that they're being asked to work, and that we can accommodate those in a broad sense whilst continuing to meet our needs. That does not mean that we've set a quota of 5 or 10 people and the 11th person, irrespective of their needs, doesn't get agreed. So I think we've met your requirements.
I think that's very helpful. I didn't get that impression when I read the detail. I thought there was too much detail, and the more detail there was leading me to believe there was a quota.
Okay, fine. So we are clarifying in the meeting.
Can I just ask Eleanor to agree whether I've summed it up
that's correct.
appropriately?
Just to put a bit more meat on the bone, so the idea is that for all the people who've put disability in their flexible working applications, we'll go back and review all of those applications, and then we will have ISPs for all of those people, and then take a decision so that we avoid the problem that you were outlining. Well, you were both outlining, like, well, you just let the first 5 in and then no room after that. And the other point is, and it's discussed a bit in the paper about litigation, and in fact we discussed it in quite some detail in the board, this issue of how do you draw the line. If you've got this big group of carers, how do you distinguish between them? And I think that's why it's important to explore options other than ISPs. So maybe you want to tweak the roster options a bit. Like, there are other ways of doing it that everyone can benefit a bit more equally from, rather than just saying, okay, you've been here the longest. So,
Okay.
does that make sense?
Yeah, I'm not sure whether that reopens the exhaustive work that's been done so far to craft the rosters. And I would take that as being something we might do in the future.
Yes.
So we're just being absolutely clear that we're not going to revisit those now, because they have been reviewed and considered and tweaked as far as they can be. Louisa, then Tim, and then I would like to ask Nick just to put it together.
Okay, so just to go back to the 90%. So there couldn't be a sort of legal challenge on the basis that 90% efficiency in our business is not practicable.
You might, if someone brought a challenge and you said, well, the reason we're doing it this way is because we need to meet this 90% target, I imagine there would be a bit of interrogation of why have you chosen the 90%, which you would need to have an answer to.
Yeah.
It's all about being able to say that you have explored all the options, and it's not the case that there has been an arbitrary line in the sand drawn, that actually there's a bit of wriggle room around. So the due regard duty is quite... So it's not saying that you have to achieve an outcome, it's just being clear that you've considered equalities at the appropriate time, had all the appropriate information in front of you, and that you've interrogated a bit, as you did with your conversation with Keith, and you've got an answer that you're satisfied with as to why it is that 90% is so important.
Because I know why 90% is important from the business, but I don't know that at this moment I feel that I really believe that 90%.
Maybe I could give another answer. I think it's important to remember that under the old rosters we were at 73%, which is massively inefficient. We have achieved 95% or near to 95% on TAL, so 95% is achievable. If we were to look at achieving 95% in our core business, that would have involved everybody, all frontline staff, going on to permanently fully flexible rotational shifts. similar to what they would work in the hospital, and we decided that that was by far a step too far to go, so we decided to keep with roster patterns. We looked at that, and 85% would still be very, very inefficient, but 95% was too much to achieve.
So, Louisa, I mean, I do recall we have had discussions earlier in the process about that 90% figure, and I'm not sure whether you were there for all of them. I mean, my sense is, I think it's absolutely legitimate that you should poke at that. It is an important thing that we, as a board, understand why we're committed to 90%. My personal feeling would be, we've done it, and this is just revisiting stuff we've done. I would just like to test that, because I think it's important that I understand whether there is a consensus around the 90%. Is there anyone else who shares Louisa's position of not yet being convinced that 90% is the right figure for us?
Or just whether it could be, I mean, my question was really around what can you challenge legally, and that was one of the things I wondered. Yeah.
I think, again, correct me if I'm wrong, but what I've heard Eleanor to be saying is, you need to have thought it through carefully. You need to have decided that it's the right figure for your business based upon sensible inputs and careful thought. I believe that's where we are. Is there anyone else? Is there anyone who has a real anxiety that we haven't gone through an appropriate process as Eleanor sketched out for us? Okay, thank you for that. Tim, were you?
Well, my point is very similar, but it's to say that if we accept this 90%, which I do, and feel that it's legally defensible with the caveats expressed by Eleanor, are we able then to go back to the RCN and say that we absolutely can't go financially beyond this envelope, but within that, what else is it that we can do to make all their members who work for us happier in this construct? Is there any, or not what else, is there anything else? Can they see any other way to do it? So can we maintain
absolutely
excellent relationships not only with the union but also with our staff in the process of implementing what has to be implemented?
Yeah, I mean, shall I try and pull it together?
Yes, please, if you would.
The answer to your question is yes. There was a national joint staff side meeting last week. I'm sure if Roger was here, he would be able to talk about the tone of that meeting, which was very positive, and there's an absolute determination on our part to continue to work to try and maximise both the business benefit and at the same time the benefit for staff, including those with protected characteristics. You made an important point earlier on, which was how would the rest of our staff feel? I'm quite clear, perhaps clearer as a result of going through this process than I was a few weeks ago, but very clear that we have a duty to promote equality. And I'm afraid that would also include articulating to our able-bodied staff, without protected characteristics, what our responsibilities are to staff, for example, with disabilities. And not shrinking from that responsibility. If we were to shrink from that responsibility and somehow regard this as an exercise in democracy, I think we would be failing in our duty.
It's called the tyranny of the majority.
Well, yes, that is one definition of democracy. Yes.
It's a risk of democracy.
Indeed. So overall, I believe that we've worked through the difficulties and complexities of this issue. We've got a reasonable way forward that meets our duties legally. I commend them to the board. I hope that you will agree with them.
Okay, I'd like to ask whether people do support that.
Yes.
Thank you, Trevor.
Could I raise one point? Having taken the decision, which I'm very happy with, could I just, for information, clarify in my own head now where we are? And it comes back to this issue about what the decision was. When I read all the correspondence, the decision, I thought, was the decision we had already taken. And that was reinforced by the Beechcroft letter, where it was referring to the RCN challenge being out of time, because it was more than 3 months after the decision. Presumably now, we have taken a different decision. We've just taken a decision. Presumably now it's open to the RCN to raise issues with us about the new decision. So the out of time issue around the RCN challenge must fall.
I was never convinced by the notion of of saying a legitimate
Sorry,
concern of
guys,
regulators
yeah.
at the time.
Yeah.
I never felt comfortable with that, but I didn't want to debate whether that was right or wrong in the public eye. But I'm quite clear that we will maintain a dialogue with the RCN and indeed other staff-side organisations, that we will continue to keep the whole situation of our rosters and their implementation and flexible working under review, and bring information back to the board as and when things change, so that we can respond appropriately. That's what we will do.
Good. Thank you, Nick. I mean, I think it is worth just pausing to note what I think has been very much in evidence, sort of over the table as we've had this conversation. I think the board has absolutely understood that the decisions that we're taking affect individuals and their lives, and that's been evident through the process, particularly in the recent weeks and the workshop that you've had and the conversation we've had today, and this painful necessity of reconciling the needs of our patients to have people who can support them at the time they want, the needs of the NHS and the broader community to be able to afford the service that we provide, and us to remain able to provide it within the targets that we're set for cost efficiency, and the inevitable impact on some people's individual lives. And that is a very painful, really very painful trade-off to have to make. And I thank everybody who's been involved in the process in this room and beyond for their contribution in trying to get us to the best place that we can get to. Thank you very much. We're going to take a break now until midday, recognising that we will be half an hour behind. So we're going to go through the next section of the agenda very rapidly. Thanks very much. Not for you, sadly. Okay, we're now into the governance and compliance section of the agenda. We have, which is mostly procedural. Can we have, please, a quick update, Alan, on information governance? So we don't have Sarah with us today, but I'm sure I know you're eminently well qualified on this.
I am indeed, thank you. Yes, Peter. Thank you, Chair. You have in front of you the progress update for information governance, and really focusing on the submission of our assessment for the IG Toolkit version 9. And you can see, I'm sure everybody's had the opportunity to look at the paper, but you can see in section 4 that we set ourselves a target of gaining level 2 compliance on all requirements this year, and in fact achieving level 3 on 14 of them. In the end, we did achieve at least level 2 compliance on all of them, including the IG training, which has been an area of shortfall in the past, and in fact over exceeded our plan in the area of level 3 by gaining level 3 compliance on 15 requirements overall. This means that our overall rating, which is now publicly visible on the Connecting for Health website, is now deemed to be satisfactory.
Very good, thank you very much. Peter.
I just have to say, well, as the audit committee took personal interest in this matter for some time.
Once a person now, the audit committee.
and I think Alan has pulled this together extremely well. Last year we didn't quite make it. This year we have exceeded it. So congratulations. I'd also like to say thank you to non-executive colleagues for completing their element of it.
Why looking at me, Peter?
Well, you were one of the first.
I thought you meant I was the last.
But this is very good, and long may we continue along these lines. Thank you.
Fantastic. Thank you very much. Any other comments or questions? No. Let's go on then to the checkpoint on our tripartite formal agreement. Trevor.
The report sets out a number of achievements in our progress along the FT pipeline. It also highlights the importance of our next review point in July. And I think that's really all I wanted to draw the board's attention to.
In the absence of questions or comments on that, thank you very much, Trevor. So we've got a updated register of interests, if anyone's interested. I presume we just take that one as read.
Yep.
And go on to the corporate risk register, which Sarah's ably delegated to you.
Yeah, well, I'm happy to answer any questions, I think.
Are there any questions on the risk register? No, thank you very much then. And now we're back, we're on to feedback from our various meetings, committee meetings. I think we have, we've got minutes from the Clinical Governance Committee in terms of reference. Have you got an oral report?
No, the meeting's on Friday.
Okay, that's fine. Sue has, of course, already orally reported on the meeting whose minutes are in the pack, so I'm assuming there aren't any questions on that. I think we have Finance Committee next. Thank you. Again, we've got minutes of a meeting that we've already discussed. Tim, do you just want to take questions? If there are any for the Finance Committee?
From the minutes from the 21st of March.
No questions, Tim.
And then there is also the work plan for next year.
Yeah.
Which I think just draw people's attention to and comments of the great community.
I'm sure Tim would be very happy to talk privately to anyone who wants to get into the detail of the Finance Committee's annual plan, unless there's any burning issue that we need to discuss over the table. Okay, that's great. Thank you very much, Tim. And Peter, again, we've got minutes of a meeting that you've already talked to us about and an annual plan. Are there any, can we deal with this in as questions? Are there any questions to Peter? No. Thanks very much. Then, for the record, we've got 3 good sets of minutes and some plans. That's great. I think there must be a record for the governance and compliance section. So we're now on to stakeholder engagement. I'm not sure if there have been any physical visits over the last month, but I think, Trevor, you participated in the National Clinical Review, and if you had any thoughts from that, I'm sure we'd be interested to hear them.
Just one point. I'm always impressed by the review system. It's very thorough and really gets to the heart of issues. But this particular case involved a nurse exercising professional judgment. And when I read the briefing papers, it was stressing that she had not followed the clinical assessment system as rigorously as one could. And it just struck, I simply raised it as the layperson listening to the discussion, that in my view, nurses exercising clinical judgment is a very strong part of the NHS Direct system, rather than mechanistically following the questions that come up on the screen. And I think people agreed that in future the briefing should be positive, should recognise when people use judgment as a positive issue, but if that judgment then results in something going wrong, we need to be open about it. But it was just interesting, it felt negative when you read the briefing, that the nurse had not simply followed the screen at times. But
Tricia, I don't know if you've got any comment on that.
Yeah, it has been something that's been noted in other reviews, that the review seems to be focused more on the punitive side rather than acknowledging the complexity that is within the service we provide, not only making clinical judgments but making those clinical judgments remotely and eliciting the advice from parents or from patients with symptoms and trying to weave and build up a picture. One thing we did learn from a very recent review is also engaging the staff, not only writing a statement but actually participating in the review itself, so you can hear the positive and constructive comments from the senior reviewers directly. And I think, trying to build that balance between acknowledging when things have been done really well and within a clinician's scope of practice, and where there is a direct and focused process to go through. Finding that balance is difficult, and we believe bringing the clinicians involved in the case actually to the peer review will actually bring more of those constructive and positive comments forward.
That's an interesting new development. Thank you. Thanks, John. Okay. Let's then move on to our call recording and service quality review. So these are both focused on the service we provide over the telephone in relation to children, babies who are less than a year old. Trisha, how do you want to handle this? Do you want to put them together, or do you want to talk about the call recording first and then the review? What's your
I'd like to take the call recordings first, please, so I don't miss the opportunity to capture non-executives' comments on that, and then step into the service quality review. Thank you, Chair. If board members recall, on previous service quality reviews, we have passed comment on how we would like to listen to calls, particularly relating to that service quality review, and in particular in the one we did for the palliative care line, and we'll bring that call to a later meeting. So for this board meeting, we agreed we would bring patient experiences and calls relating to babies less than 12 months old, because the service quality review will go on to discuss is relating to babies of less than 12 months old. So these three calls are here relating to adults calling on behalf of their children who are under 12 months. There was 3 calls, so you could get a thorough understanding of the process and the patient experience. All the calls came to an urgent endpoint, which I believe reflects the difficulty we can have in managing very vulnerable and young children. And I'll leave that at that point, just to take comments back from board members.
Fine. So we had 3 different episodes, didn't we?
Yeah.
With listening to both the health advisor and the nurse advisor, and in one case the ambulance as well.
Yeah.
Who would like to just provide any thoughts or comments on those?
Can I just say I only managed to listen to the first call, so
Fair enough.
apologies.
Okay. Did everyone else manage to listen to the calls?
Yeah.
Thank you.
I don't
All
know,
right.
start.
Yeah, sure.
No one else wants to offer. Just on the first call, I mean, in all calls, as an overview, I felt that there was mostly a calmness around the approach to each of the cases, and both the health health advisor and the nurse advisor were in tone were extremely supportive, and in the last case particularly caring. I mean, I'm not saying the others weren't, but I think she got the sense of the crisis that that particular individual was in, because I think the other 2 parents were relatively calm and coping. And sometimes I always think the admin sort of gets in the way of the clinical conversations. Yeah. Well, that's my concern, because sort of jumping in with date of birth, where you live. I know all of those things are important, but it sort of destroys the relationship, I think, sometimes with that individual. I don't know quite what can be done about that, but perhaps once you've given that stuff, do you always have to sort of reinforce it? I don't know. So that was one thing. I think the other thing was when sometimes they're asking, the nurse advisor particularly is asking the parent or the guardian to give an opinion about a clinical circumstance. I think they struggle with it sometimes to understand what's being driven at, and particularly around the rib cage thing, and that sort of flaring nostrils and the vomit. I don't want to go into that, but the colour of it, and whether it had bile in it or whatever, important as it is, I think that's quite difficult perhaps for the parents to perhaps relate, well, easily do. That's all. I thought the nurse in the last case and the nurse and the health advisor gave some were reassuring to obviously a nervous mother. I know it says she was crying. I didn't quite hear that. But she was certainly concerned, and they did wrap their arms around her metaphorically, I feel. The nurse advisor in particular. I thought she was clear and understood what she was driving at, and she quickly, even though she had these obstacles of bureaucracy in the way, she quickly came to her conclusion it needed an ambulance, and she got on with it, and she, I think, reassured the mother about everything as best she could, and she got on with it, even though there were some hitches, and then went back to told her what was going on. So I felt that she was very empathetic, and but also reassuring. It's more than empathetic; she was reassuring. So I thought they were good calls.
I'm going to stick myself in the to pick up on a couple of those points. I also thought the right answer, it just felt that as though the service recognised where the parent and the child were and responded. I also picked up, like Peter, that it was sometimes difficult to be sure that the parent had understood the question being asked, and the one that particularly struck me was pinprick rash. So the question asked, is it a pinprick rash? And I think the mother said yes with a question mark in her voice. Yes, and that, it seemed to me, was she's actually signalling, I've got really no idea what you're asking me, and so I'm saying yes, and that seemed to me could have merited a bit of unpacking, because I'm not sure I know what pinprick rash is. And I think she was clearly signalling that she didn't really know either. And I thought that one of the health advisors wasn't speaking clearly enough for the caller to understand what they were saying, and the caller repeatedly said, sorry, don't hear. And that happened in a number of times. So clarity, and I think this has also come up again, that whatever the quality of the service is, it's like being a presenter, isn't it? You have marvellous slides and a brilliant argument, but actually the people back couldn't hear you. There's a bit of that which is tremendously important for us. And then finally, maybe I'd like to come back to the comparison of what the outcome was, the outcome that the callers received from our service, and what we think the 111 outcome might have been, speculative as it is. And it seems to me that there was an interesting lack of congruence, really. I think 2 out of 3, what we're saying is 111 would have given a different answer. One more urgent answer and one less, and I think that's an interesting thing just to think about. So I saw a number of people with hands, and I think this is the order in which I saw them. Tim, Sue, Louisa, Tim.
Yeah, just to pick up something Joanne said, I think it was the male person on the second call who spoke quite quietly and not clearly. Asked, just a trivial point, but asked which county they were in rather than which town they were in. I can't remember now, but it didn't feel quite right. The thing that really, 2 things struck me actually. One is, by definition, these calls are going to take longer, and they were long. And I don't feel that's a criticism. They have to be a bit longer. Keith's going to keep me under the table. The other thing is, the ambulance service, we have this view that our service is a bit clunky and we ask for information repeatedly, but the handover to the ambulance with the nurse, who was doing a fantastic job in calming the mother, but the ambulance service asked for the phone number about 3 times, they asked for the address 2 or 3 times, and then their automatic messaging was breaking in. I don't know whether the mother was hearing that automatic messaging from the ambulance service breaking in, but it was pretty appalling, I think, the handover there. And yet, at the same time, our nurse was doing a fantastic job in being very calm and very caring for both the child and the mother, with all these other interruptions coming in. So I think that interface might need a little bit of looking at.
Well, I think we can be reassured that in 111,
it'll be
the person who answers the phone will be able to dispatch the ambulance. So that slightly non-seamless handover should disappear.
Yeah, well, one final thing is, which occurred to me again, and we always say, if the line goes down, we'll call you back. And yet 111's a no callback service. And I just wonder whether that's been fully considered in the design of 111, because if the phone does go down, if you're holding a baby and you drop your phone and it switches off or whatever,
Well, that's a question of fact, isn't it?
It does a lot.
It does. So we can clear about that. Thank you.
It's the clinical safety aspect that that element of callback is appropriate.
Perfect. Okay.
Thank you.
Sue.
Yeah, I thought all three calls were very reassuring, as has been said. I think they sort of reflect the sort of higher potential risk because they're very young babies that we're talking about here. And I was trying to decide as a layperson, call 2, for example, we ended up take to A&E. And yet, during that call, I wasn't quite sure I understood exactly how we got to that particular disposition. I don't know. And yet, the third call, I was surprised we didn't get there quicker. And I felt that we might have introduced a bit of a delay, actually, into that particular call. Because you're right, the calls are very long. And actually, almost did we delay that? I don't know, by having the health advisor and the nurse advisor in that. Yeah, that's it.
Well, again, interesting comparative to 111.
Exactly. Yeah.
I'll ask Trish to come back on this. Louisa.
I thought that it shows in a way how difficult it is to do an over-the-phone sort of triaging service, and so so much time spent on the first call saying are you child, can you see the the line. I mean, shows it is very difficult, and I suppose you wonder how much value there is in going down some of those paths. I think that often it's good when the person on the call says why they're asking something. I mean, even just say I need to check on the date of birth. I know it adds time. I don't know how you do that, but just to explain why you're asking again for something, I think is helpful. Just leaping around, I did wonder whether it was possible with the calls when we go back to find out what happened to the children. I sort of, better off health-wise, I sort of think that I kind of wanted to know, it's like a detective story, what really happened. Because I think that would be really helpful. I didn't hear the second call because I didn't have time, because they were surprisingly, well, I mean, they obviously weren't surprisingly long. And with the call, the third call, I thought the nurse was absolutely fantastic. I was almost moved to tears by how brilliant she was. And when I saw that it was 10 minutes, I thought, oh my goodness, get this baby to hospital. But of course that time was all with the ambulance service. And the only point that I would make about the which I think is often a problem, is that the health advisor, there was a whole issue around, does your baby have a temperature? And so she said, it's normal, the baby's hot, I'm not sure. He kept asking, and I sort of, it worried me that he was thinking that she was saying it was not, the baby was normal, didn't have a fever, and yet I thought she was saying that the baby did have a fever. So it's that sort of clarity around how you deal with that and how you make sure you've really got the answer that you want. And that was it. But I thought it showed some of the most, fantastic aspects of our service, really.
Thanks, Louisa. Tim.
Just two observations. One, I thought it was extremely difficult to sort of inspect your baby, undress them and so forth, whilst holding a mobile phone in one hand. I don't know how you get round that particularly, but I do think it's a little bit much to ask of a distressed mother calling to pick up the baby and do things whilst still on the phone. So there might be a way around that. The other observation I think really echoes what Louisa's just said, and that is that we did seem to be asking the parents to make much more of a clinical assessment than I think is perhaps reasonable. And the thought and how questions are worded might be worth doing. But having said that, the outcomes all sounded very sensible.
Yes. Could I come back to the, before asking you to come back, Trisha, the comparison of the 0845 outcome and the 111 hypothesis? So I think what we were saying was, so we know what the outcomes were on the 0845. The first was A&E, second was A&E, the third was 999. We think that from 111 we would have got a 999 ambulance for the first call, urgent GP appointment for the second, and a 999 ambulance call for the third. So the first two, they were sort of, one would have been more acute and one would have been less. Do you think there's anything to be read into that?
It's difficult, Joanne. I think both services, both 111 and our core service, does demonstrate in such very young babies, you are more likely going to come to an urgent end point. My clinical judgment on the first two calls were those children possibly would have been best served at a GP out of hours with an urgent appointment. So a GP out of hours, not 2 hours, may have been more appropriate for both those very young babies. The absolute one I agreed with, the outcome was for the newborn baby with the distressed parent, to call 3. But each service, both 111 and our core service, is rightly referring vulnerable babies to urgent endpoints.
Yes, okay, that's great.
If I can just...
Yeah, if you could.
Yeah, if I can just... Pete's comment regarding how the administration disrupts the interaction, I agree with that. And with our telephony refresh in the introduction of the PDS, where demographics will be automatically uploaded, will have a positive impact on that. It will make it the flow slicker in that those demographics will be readily available rather than the patient having to repeat them or type them in, rehearse them back. There are appropriate governance processes why we have to validate certain aspects of the patient demographic, but you do, when you listen to more calls, there are slicker, smoother ways of building that into the process, but certainly that development will improve things for the patient experience. I do agree with the empathy and the reassuring in all of the calls. The health advisor who was not being very clear with his enunciations and engagement is absolutely a valid point. And as you quite rightly say, Chair, the dispatch of ambulances in the future 111 service will be smoother because we will be able to do that automatically without having to go through the process of BT and repeating demographic information at the end.
Okay, thank you. I think the one thing I would just like to take forward was Louisa's point about it'd be nice to know what happened.
Yes,
and if we are going back to callers to say, are you happy for us to listen to your call and talk about it, then I think we could presumably ask them, and actually what happened? And that would really, what did you do and what was the outcome? Which would make these an even sort of richer conversation. Thank you for that, that's great. Shall we then move on to the service quality review?
Yeah, okay. So in keeping with our service quality reviews, this is the 10th of those reviews. Again, with regards to babies under 12 months old. I'm happy to take any questions, but in summary, it's the final review and it highlights the service that you've just experienced in those calls that you've listened to. The action plan is there and will be monitored in line with the other service quality reviews through the clinical governance process, but the majority of those actions have already been taken forward and implemented.
Would anyone like to make a comment?
It was a question, sorry. It was a very small, picky question. So it was just on the business of being able to search calls for age. And it says here by the end of March 2012, so clearly whether that action has slipped or whether we know the answer.
I'll have to come back to you, Nick, on that. I know it's for the core review team. It's for Shirley's team when they're actually doing this kind of review. We wanted to have that search thing there, but I'll have to come back to you on that.
So,
I should have asked you this before because I've heard the report. Can you look at page 27? Page 27.
Yeah.
I was just struck by listening to those 3 calls. I was saying that we're likely to have a more acute call when it's very young babies.
Yeah.
So looking at these outcomes, and actually what we have, if I understand the way our outcomes normally work, we've got a much higher urgent outcome. and with only 24% self-care, and the rest is either GP next day or actually I was looking particularly at the A&E and the ambulance, 23%. That's high, that's significantly higher, isn't it, than normal?
That's in keeping with this age group.
Yes. So
yeah.
what worried me was we talk about here saying that self-care dispositions are below national organisation aims, and we're going to try and drive that down because of best practice.
Yeah.
But I was slightly worried that didn't take into account the fact that actually this, as a small, discrete group, you wouldn't expect self-care to be as high in this group. So is that right?
Yeah, I take your point, Sue. I think the people who undertook the review recognised that we could have achieved a little more self-care than we actually did do.
Okay, so it's not an attempt to push it to what we do.
We're not
on
striving
average
to drive inappropriate self-care endpoints, but there was an acknowledgement that there were some calls during the audit where, with a little further questioning and critical thinking by the clinicians, self-care could have been achieved, or a less urgent referral.
Okay, I'd like to make a comment on that and put myself in there, and then we'll go to Louisa. So my response to that would be, the nature of our service is such that I think we ought always to be looking for more opportunities for self-care, because we start with a service where safety is our priority. And so as we get, we accumulate more and more and more experience, what that enables us to do is to move the boundary so that we send fewer people away from home unnecessarily. Yeah. So that seems to me to be not that we're striving to reach the average for any particular group, but the benefit of experience is being able to get better and better at understanding that boundary. I would just like to ask a question about figure 1. 2 questions really. I think there are 21 pairs of data and 11 labels. So we've lost page 13. So I think what we've lost is sort of half the labels, probably because there isn't just enough room to put them on, which makes the chart quite difficult to interpret. But the question I had, so I think it'd be useful, Tricia, if you wouldn't mind sending around the full version so that we know what it actually says. What are the distinctions between unwell or crying newborn, 0-3 months, crying newborn unwell, 0-3, crying newborn, 0-3, unwell or crying, oh no, that's an age group. So those first 3, how on earth, how does it work? There must be differences between those that I didn't quite understand.
There is very slight subtleties within the algorithm and the endpoints, because we have recognised through reviews of serious untoward incidents that we need to acknowledge the under 3 months. So where we listen to that final call where it was a newborn, we know that from 3 months to 12 months old, the baby is slightly more robust and will not have any, or you'll have moved beyond the potential of undiagnosed birth defects and things.
So what about the first 3 that all seem to be the same age group?
Yeah, it gives the clinician an opportunity to choose the algorithm. They follow virtually the same path, but is it unwell, or is the child unwell or crying, or is the digging a hole? I'm just going to go there are subtleties within the algorithm. I'll quit while I'm ahead.
It would be really helpful just to get the full thing, and maybe something that explains those differences. Thank you. Louisa.
I'd like to have seen more sort of specific, sort of granular stuff around some of the really important issues in this paper. So, one of the questions, maybe it is in here and I've missed it, is what proportion of calls are babies less than 12 months old? And I wondered if it was a bit like sort of colorectal surgery, that if you do a lot of it, then you're very good at it, and if you don't do very much of it, you're not very good at it. And how many of these calls would somebody be likely to take? And then just around some of the things around involving, our fantastic sort of members and all the other things we have, would it be nice to have seen some sort of specific things. So around user experience, patient carer, it was very general, and there wasn't anything here that said to me, this is what, maybe we don't do anything particular around babies under 0 to 12. Although here I think we do around our net promoter scores, but there didn't seem to be much sort of qualitative stuff around that, but maybe I've missed that. I did wonder a bit about, I looked at the self-care thing and thought, well, very difficult to get that up. But then there was a sort of bit that seemed to be missing, which is it very difficult, do we think, to differentiate between a child who needs to go to A&E or have an ambulance, and to have a GP come round in a sort of short space of time, and whether that, would then, as you say, Joanne, keep somebody with their baby at home. Is there something in algorithms perhaps that doesn't come up as a choice, or we're more anxious about giving that?
I suspect that those are quite subtle questions you're asking, Louisa, and it might be helpful for you to have a chat with Tricia offline. I think it does raise a question about what we're really getting at in our service reviews, but whether it's actually helpful in the sequencing to do that now, I'm not entirely sure. So,
but can I just ask a question about is there a subtle question about do we have a sense of how many people get a disposition around a GP coming to the house or getting onto a GP?
GP out of hours services give us very strict criteria which are to be met prior to us offering a home visit. So we would be more likely to ask the family to take the child to the GP out of hours service because of the equipment and the availability of staff there, rather than do a home visit.
So would that be here? So we've got A&E, ambulance, GP next day. Where would the going to a GP out of hours be?
It's not captured in there. I'd have to come back to you later on that, because that actual figure which sends them to a GP out of hours is not in that figure. It would come between the ambulance, accident and emergency, and GP next day. There's a figure missing there.
Okay.
I think the answer to your how many calls question, Louisa, is sort of buried on page 9, 62,000 in 3 months.
Right, okay. Well, it's very nice you say buried. I mean, I didn't read it carefully enough. Okay, thanks.
You have to.
The review period.
I'd like to give credit to both writer and reader. It was there. You just had it. Okay.
But I need to.
Yeah, and then if you want to ask the question, well, how likely is a person to, or how frequently will a nurse advisor get a call?
Well, I wasn't sure about that when it meant total calls to the service. This is total calls of 0 to 12 months.
Yes.
Okay.
Yeah. Otherwise, we would have a much smaller service than.
Yeah, got it.
Yeah.
Thanks.
Sue.
Can I just share? I personally would like to be able to get greater granularity around patient experience, specifically around that particular age group, for example. And you're right, there is a lot of general sort of net promoter overview, and we haven't yet been able to get to the granularity, which maybe when we come to 111 we'll be able to do that, and maybe not. I don't know. The one thing I wanted to just raise was that we're coming to the end of these service reviews, and at the Clinical Governance Committee on Friday we're going to sit down and consider where to go next, and what to do next. We're continuing to review the implementation of the recommendations, but there is a question mark about what happens, what's the next step.
And if I could just add, Chair, that the considerations of where the organisation is here and now, and the pressures we are under with our current bids, etc., did mean that this service quality review had to be at a high level because of the pressures on individuals who would have contributed to the service quality reviews their time. So we did give permission for this to be high level in order that we as a board could have an oversight as to how our service to this age group is provided, but there was some demands on individuals.
It's really helpful to hear that, Tricia, I think, because the report as written does exactly that. It reassures us overall. It doesn't dive down. And now we understand why that's very helpful. Brian.
Yeah, it was just 2 points. One on that was that there is a difference between the service quality review and the clinical audit, which will have much more granular, much more detail about the clinical process following some of these children through. So that's where we see the difference within, the clinical governance label covers both of those, service quality, but clinical audit is a different process. And the second thing is that, yes, and we are collaborating with other stakeholders and the department to develop a patient-related experience measure specifically for childhood and children of this age. So that isn't going to happen shortly, it's going to take a bit of time, but that is the process of looking exactly at families' experience when they're going through the health service, including our service.
Right. Okay, that's great. If we could, Keisha, you might want to just pick that up for the minutes by having a chat with Brian. Okay, thank you very much indeed. Thank you, Tricia, for that, for both of the call recordings and for this, and to your team. We do recognise the pressures on the business overall, so it was great that you were able to provide those. I don't think I've been told of any other business. Does anybody want to bring anything up now? Okay, in that case, we'll be meeting again on the 28th of May here at 10:30. Thank you, everybody, for participating. If anybody's watching us online, could they please fill in an evaluation form? And I'm going to take a short break to grab lunch. I think it would be helpful if we could bring lunch back to the table.